Thank you very much, and thank you for the invitation. I am here filling some shoes that are impossible to fill because Dr. Byers was going to talk about this. Unfortunately, he couldn't make it. So I'm going to take you out a little bit of EDS for a moment and focus on all heritable disorders of connective tissue, and then we will go back to specifically the Ehlers-Danlos phenotype itself. If you look into the database of genetic disorders that Dr. Makusik started, there's over 1,000 different disorders that will include connective tissue disorder within their descriptor. So it is by no means exclusive just to the ones that we recognize. Shared features that will make a patient be classified into this major group of connective tissue disorders and maybe be referred to a genetics clinic for evaluation would include features like you see here, the increased flexibility of the skin and joints, variable degrees of tissue fragility that will include easy bruising or poor wound healing, either or both. And depending on the function and site of expression of the protein that's involved, we may have additional tissues involved, such as the heart, the vessels, eye, and other systems, which may explain in part the variability that we're seeing. So what is connective tissue? Ultimately, all of these disorders are affecting the extracellular matrix. We tend to think of cells as individuals and not individuals in a three-dimensional context in which they need to communicate with one another and to everything that's happening below and above them. So this connective tissue is going to allow them that and is going to provide them with support. As you see in this schematic, we have a formation of elastic fibers. They link those elastic fibers to other components of the extracellular matrix, and they anchor the cells in place. Every tissue will have a component of extracellular matrix. Within it, there are several components. So another thing that you read often and that you find in the literature about these disorders is it's a collagen disorder. It is, but it is not. Not all of them are due to changes in collagen, and they can be due to changes in enzymes that modify the structure of that collagen, the integrity, or how that collagen connects to other proteins. There's elastic fibers, and there's at least 8 proteins that form what is known as the microfibrils that I also think have not been studied in enough detail. To join these all together, there's also the glycosaminoglycans, which are particular proteins that have sugar content in them and that are like sticky and maintain those bonds. The reason why I'm bringing this up in the context of the genetics lecture is that although I hope that at the end of this meeting we will have a clear management of the patients, I deep inside believe that unless we understand what's going on at the molecular basis, we're not going to be treating the actual origin of the disease. We're going to be treating the symptoms, and that's why this is the area that I'm focusing on. So what do we know about collagens? Collagens come in many varieties, but in general they are formed by 3 chains, and those 3 chains are all in alpha configuration, and they twine together to form these fibrils that then align with one another very neatly to form those collagen fibers that we see on the right. Collagen type 1 is the major component of the bones, and it's the most abundantly expressed protein in the body. If we were going to analyze, the majority of our composition in terms of protein, when you counted all the bones, would be from collagen type 1. But it's also expressed in the skin and in the sclera of the eye. The most common disease associated with this would be osteogenesis imperfecta, and those patients will have fragility and will have fractures. But you will see that some of the patients with EDS may also have fractures, and sometimes that will be our initial clue as to EDS. As I said, there are different proteins that modify and interact those collagens. One is lysine hydroxylase, and for the remainder of the talk, you will see the gene names in yellow. This one adds a particular change to a lysine residue in the collagen fibril and provides it with stability. Then there's an ADAMTS2 gene that is important for cutting the tips of the collagen fiber, and when it fails, it leads to the severe form of EDS. And then the tenacin X that has been available for testing, and that explains a very small proportion of patients, so small that, as Julie's pointing out, we don't really clinically test for, but does explain some of the features. And both absence, decreased quantity in some of the individuals, as well as absence of tenacin X may lead to presentation of the Ehlers-Danlos type. So the microfibril that I had told you about is composed by these proteins that are listed in the table, and I would like to highlight some of them because there are disorders that you already know. Fibrillin 1 associated with Marfan syndrome, and we start seeing the overlap. Okay, so connective tissue, conditions that are mixed in the differential and that sometimes prompt even physicians to get confused. Latent transforming growth factor beta, which is a very critical master regulatory signaling protein that I think might be important in the expression of some of these symptoms. It comes in 3 types, fibrillin 2, and then other associated proteins to the microfibril. And finally, the glycosaminoglycans that, as I told you, form these sticky connections between the fibrils. So here we have the collagen fiber, and we have attached to it a decorin protein. There are mouse models that show that in the absence of decorin, these fibers don't align nicely, but they are actually very disorganized, and the skin of those mice is very disorganized. So there we can replicate the phenotype that we get in those conditions. They also play a role in regulating the function of morphogens. So there's a lot of signaling mechanisms that are happening to the cells and that are happening depending on the availability of these molecules to them. So as you can see here, these chains that form the extracellular matrix attach to these morphogens and prevent them or allow them to start a signaling pathway to the cell. In Marfan syndrome, it has been shown that the downstream effect of the defect in fibrillin is an increased expression or an increased activation of the TGF-beta pathway. And the therapy that is being used right now to prevent the progression of the aortic dilatation is primarily targeting that TGF-beta pathway activation. So we're not replacing fibrillin, we're not replacing a structural protein, we're just preventing what the absence of that protein is doing to other cells. And I think that if we find something similar for hypermobile EDS, we may be able to address it at that level. So which ones are the disorders that we know of? Marfan syndrome, that will have a characteristic body type that was alluded to. So tall with relatively long limbs in relationship to the trunk. There's involvement of the eye, and there's major criteria that includes the lens dislocation and minor criteria in the eye that includes myopia. For the heart, the aortic root dilatation that is present in these patients, and mitral valve prolapse as a major criteria, and is caused in the majority of cases by fibrillin 1 mutations. There's also Lloyd-Dietz that at the beginning was thought to be very rare, and now more and more patients are coming with this diagnosis. They have a body appearance that may resemble to a certain extent Marfan, but they may have other systems involved, such as the palate. So there's a bifid uvula that you need to look for in the examination, and the vessels are very dilated and tortuous. The genetics are TGF-beta receptors 1 and 2, and other proteins that are involved in that pathway. Ehlers-Danlos are very heterogeneous, as we already discussed, and we heard about the nosology, so I'm not going to linger there. 6 major types, and of the major types, we do have good correlation with some of the genetic basis of them, but type 3 hypermobility type we have not been able. So classical type, depending on where you read and how the patients were selected, it has between 50 and 90% pickup rate if you do testing of collagen type 5. And I see Hannah making a face of, well, I don't know. But again, referring to the paper of Malfait et al. From the Ghent group, they say that if you're very strict with the criteria and they really have widened atrophic scars and the joint hypermobility and stretchability, they can pick up mutations in 95% of the patients. That is not our clinical experience. We still have many patients that don't have mutation positive. There's also null mutations, so inactivating mutations of one of the copies of collagen 1A2. This one is the one that in a few patients they have found complete loss of function of this tenacin X protein, so both copies would have been lost. And finally, the skin biopsy. If you look at the collagen fibers, you may see these particular cauliflower appearing fibers. That is why in some of the patients we use skin biopsy as a means of diagnosis. The problem is a skin biopsy is an invasive test that will cause pain in a patient that is already in pain. So we tend to postpone that to at least until after collagen 5 analysis has been done, or if there's going to be a surgical intervention, at which time the skin biopsy could be done. You also have to have a good pathologist that is able to interpret the electron microscopy and see those changes. The hypermobility type, as was mentioned, needs a new definition. I think that the other thing that I took from the meeting in Ghent was that there's no good, there may be subtypes. There may be some patients that have many systems involved, and then there may be groups of patients that just have the hypermobility and pain. And therefore, we need to do a very good job at distinguishing the different types if we're going to be able to get to the genetics of it. Vascular type I told you about, the fragility, the thin translucent skin, arterial, intestinal, and uterine fragility. Generally, there will be a family history of early death. And this one, there have been a lot of efforts into treating because of the lethality that it's associated with it. In terms of diagnosis, these patients have a change in collagen type 3, and it can be detected by sequencing that gene or by doing a skin biopsy and then looking at the reverse. You use the RNA and you convert it into DNA and you sequencing and you find the change. There's other that are less common. So kyphoscoliotic EDS, remember I told you there was a modifier for collagen, plot 1, and when that one is not working, you end up with a patient that is very flexible, but that also presents with scoliosis. This one perhaps will not be in the differential of the classic and the hypermobile. It's more in the differential of a baby that's presenting with early scoliosis that we don't know how to explain. This brings up also the possibility of doing testing by measuring in the urine the residues of the effect of that protein. So that is a diagnostic test. It's a diagnostic test that's not available in Canada and that it's relatively difficult to send to the States because it's urine and not DNA. So we may consider that as part of things that are missing here, gaps. The arthrochalasia type is a severe form due to collagen 1, but it's for a collagen 1 abnormal protein that is made. So it skips an exon, and therefore it's a collagen 1 that has a different function than what it should have. And the dermatoparaxis type has the severe skin fragility with sagging, redundant skin, and this is the one that's due to mutations in the enzyme that clips the collagen fibers, the procollagen, and converts it into mature collagen. There are other syndromes that, I don't know how I'm doing in time. There are other syndromes that have been described in this group of the Ehlers-Danlos. And the reason why I bring them up is because I think that very rare single gene disorders may inform about more generalized syndromes. And if we end up concluding that EDS hypermobility type is more of a heterogeneous multifactorial disorder, some of these single gene defects may give us clues as to how they end up happening. So one is progeroid type. The other one is musculocontractural type. And then the last one is the spondylometaphyseal dysplasia Baton type that was published by the Malfay group as an EDS-like syndrome. So the progeroid type was the first one to be described among this group. And you see the patient in the old article picture, but he has a little bit of the facial features that you would appreciate in the vascular type. And then in the hands, there's increased number of creases, and there's the tapering fingers and a little bit of hypermobility. And that one is due to one of the enzymes that is critical for making these glycosaminoglycans that I talked to you about. Then we and others described this in 2013, the EDS-like SEDL Baton type. And these patients initially have contractures, so that in that sense it's distinguishable. There's club feet, but over time they evolve to have significant hypermobility and scoliosis. So we have this girl and her sibling that is older is significantly hypermobile. And the musculocontractural type also starts with contractures at birth and distinctive facial features, but they have poor wound healing, hypotonia that leads them to neurology. Actually, these patients ended up having a muscle biopsy as part of their workup. They develop kyphoscoliosis, and they do have some central nervous system alterations. This is the patient. As you can see, the hands also have a little bit of that swan neck appearance when she extends her fingers. This is after a very minor fall, a hematoma that she had underneath her skin. This is a change in her skin at the elbows, and that's a scar from also a playground fall. This patient suffers from a lot of the non-specific pain. It hurts for her to brush her hair, and it's becoming a big issue for her to attend school. So, what do we know about the genetics? I think that this is kind of a conclusion. We do have a common pathway that includes as a common factor the connective tissue, the extracellular matrix. We know the players, but we don't know them all. If we know more of the players and we know how they interact and how they regulate the signaling molecules, we may be able to develop alternative treatment strategies. For this, we can take advantage of the techniques that are available now. Whole exome sequencing allows us now to read all the genes in the body, at least the coding parts of all the genes. And there's another technique that is whole genome sequencing. The problem is interpreting the information from those tests. And the best way to feed into a pipeline like this is to have patients that are very well characterized. If you give the scientist patients that all have the same, and we're sure clinically have the same, we're very likely to find a common genetic problem. If we give the scientist a combination of patients that may have one cause in one cause in the other, it's going to be very difficult to identify one hit. So it's up to us clinicians to develop the ways to characterize these patients, to make sure that what we're interpreting as a common group of patients really has the same disease. And that, I think, is very difficult. And that leads me to the last point, which is I think we need to develop strategies to further refine those groups, perhaps by doing MRIs in a systematic way and classifying them by whether they present or not with MRI abnormalities, maybe by analyzing their muscular function, or maybe by whether they have POTS or not. We have to start somewhere so that we can identify perhaps the genetic basis of those and then develop treatment strategies targeted to those symptoms. Thank you very much.
Thanks very much, Dr. Mendozza. Any questions? Dr. Chen.
Let's say if I send you a patient, especially after diagnosis, the physicists say that it's a very difficult diagnosis to establish. How likely that you can find a genetic mutation that can explain the abnormality?
That's a charged question. It depends on what your patient has. Lately, we have been testing all patients that have significant hypermobility with a Baton score greater than 5 and skin hyperextensibility. We at least offer them COL5A1 and COL5A2 mutation analysis. Those that have a positive family history, we have been also offering skin biopsy in one of the affected members of the family and sending that for pathology. I must accept that our pickup rate is low. I would say that in the 30% of the patients that are referred. The patients that don't have many symptoms, that are just very flexible but don't have pain, tend to not go for the testing. And I don't push it because I know that the yield is going to be low. The patients that have many symptoms want as much testing as possible. And I think that if you have decreased bone density, then you can definitely look into collagen 1 and see if it's one of those. But still, the bulk of patients that are referred for hypermobility, we end up not having a positive result, at least in my experience. I don't know if in the adult or if in your experience it's different. You don't do testing?
Five?
Just how important do you think polymorphisms of particular genes are? Is that
I think that polymorphisms may be the explanation in some of these cases, and the problem with polymorphisms is that we would overlook at them when we're analyzing for mutations. We would not be looking for specific pathogenic changes, but we would be looking for polymorphisms. If we had a national strategy and we were looking all together for those polymorphisms, they may emerge. But again, you need to have a good idea that you're comparing the apples to apples and not a combination. Yeah, there for sure there might be polymorphisms.
I think there's value in terms of good phenotyping and trying to place patients in various subtypes. But then the actual potential harm there is that you miss studying certain genes that may be a player in, say, hypermobility DS. And I can think of a particular case where there was a much older lady I saw who had very significant hypermobility, but she didn't come with a very significant pain syndrome, but it had a spontaneous perforation of the colon when she was having a routine colonoscopy. And that happened twice on separate occasions. And finally the surgeon said, does she have a connective tissue anomaly? And her Baton was 9 out of 9 at 75 years of age, which is abnormal. So she's very flexible, and we sent for COL3A1. She didn't have a mutation. She had a variant that had been described in the lab in a few families who had hypermobility. So I think the risk when you say you have a vascular subtype and you have this is that you overlook genes that could be players without having to look at new genes for things like for a condition you know well.
So going back to what this group can and may be able to accomplish is, the more that we have to send this test out of country and out of province and out of somebody that is helping us analyze it, the less likely we're going to be able to find these rare occurrences, because there's strength in the numbers. So yes, you're absolutely right. If we had one reference point, one reference center, and that's to a big extent what Dr. Byers' lab was for certain genes, but he doesn't even do sequencing for COL5. So you can send a skin biopsy and he will look at COL1 and COL3, but he won't look at COL5. And so you send it to another lab, and the other lab sends you the report that they have not seen it in their patients. Well, if we can dream, we will set them up in Canada.
Yeah. I just caution you against giving gastroenterologists and surgeons another reason why they might accidentally create holes in the colon.
Okay.
I would keep that one quiet. Our next speaker, we're very pleased to welcome this evening Dr. Frank Amano and Dr. Henderson from the